In pediatric nephrotic syndrome, the body's carefully maintained fluid balance collapses. The defining trigger of this collapse is heavy nephrotic range proteinuria. Clinically, this means spilling over 3.5 grams of protein in 24 hours, or a spot urine protein to creatinine ratio exceeding 2 milligrams per milligram. This relentless urinary protein loss strips the blood of its albumin, resulting in profound hypoalbuminemia. As the liver desperately attempts to compensate, it alters lipid metabolism, establishing the third pillar of the classic clinical triad, hyperlipidemia. This condition affects 1 to 3 out of every 100,000 children, with the highest concentration of cases occurring between the ages of 2 and 7 years old. While the patient presents with widespread multisystemic failure, these symptoms are not separate diseases. They are the inevitable downstream consequence of a single mechanical failure. To find that failure, we have to look at the kidneys, the organs responsible for continuously filtering the blood. Zooming in on the anatomy, we find the microscopic functional unit doing this work, the nephron. Within each nephron sits the glomerulus, a specialized capillary tuft sandwiched between afferent and efferent vessels, where the actual filtration of blood takes place. Under healthy conditions, this tuft acts as a highly selective sieve. It allows water and small solutes, the ultrafiltrate, to pass into the urinary space, while strictly retaining essential macromolecules in the bloodstream. To understand why this selective retention fails in nephrotic syndrome, a standard light microscope is insufficient. We have to map the specific cellular architecture of the barrier itself. The glomerular filtration barrier consists of 3 distinct layers: a fenestrated endothelium, the glomerular basement membrane, and an outer epithelial layer. This illustration highlights the outermost layer, constructed by highly differentiated epithelial cells known as podocytes. Extending from the main body are long foot processes that tightly interdigitate around the basement membrane. Located precisely between them is a specialized junction called the slit diaphragm. This diaphragm acts as the final gatekeeper of the barrier. It physically and electrochemically repels large proteins, ensuring they remain safely in circulation. As long as this intricate podocyte architecture remains intact, the systemic fluid balance of the entire body holds steady. However, this architecture is fragile. Following a viral infection, or an immune response, or due to genetic mutations in the NPHS1 or WT1 genes, the podocyte comes under attack. This insult triggers the hallmark pathology, podocyte effacement. The structured foot processes lose definition, flattening and melting together to lose their intricate interdigitation. This morphological flattening destroys the slit diaphragm, opening a direct pathway from the blood into the urinary space. Without the slit diaphragm, massive, unchecked quantities of albumin bypass the broken barrier and spill directly into the urine. This localized structural failure at the microscopic level is the singular mechanical trigger for the devastating clinical cascade that follows. The most visible manifestation of this cascade is profound systemic edema. The underfill hypothesis argues massive albumin loss drops oncotic pressure, leaking plasma water into the interstitium. This triggers the RAS pathway, retaining sodium and paradoxically worsening edema. Conversely, the overfill hypothesis posits primary renal sodium retention directly drives vascular expansion, eventually forcing excess fluid out. Regardless of the primary mechanism for the edema, the systemic fallout continues with the final symptom of the triad, hyperlipidemia. Detecting the critically low oncotic pressure, the liver reacts by ramping up general protein synthesis. In doing so, it inadvertently overproduces lipoproteins, while the catabolism of these lipids simultaneously decreases. The classic triad of proteinuria, hypoalbuminemia, and hyperlipidemia is a direct, logical chain reaction, all tracing back to the broken glomerular barrier. Albumin is simply the most abundant protein lost in this cascade. The leakage of other specific blood proteins creates severe, invisible complications. The damaged glomerulus allows for the urinary loss of critical antithrombotic factors, specifically antithrombin 3 and protein S. When the loss of these natural anticoagulants is combined with the liver's compensatory overproduction of fibrinogen, the patient enters a severe hypercoagulable state, creating a high risk for venous thromboembolism. The immune system is simultaneously compromised. The patient loses vital immunoglobulins, primarily IgG, along with alternative complement pathway factors B and D into the urine. Without these circulating factors, the body suffers from impaired opsonization. It loses the mechanical ability to effectively tag invading microorganisms for destruction by white blood cells. The clinical consequence is an extreme susceptibility to infections from encapsulated bacteria, frequently manifesting as spontaneous pneumococcal peritonitis or bacteremia. Simply managing a patient's fluid retention is insufficient. Until the structural integrity of the podocyte is restored, the child remains at imminent risk of fatal blood clots and overwhelming sepsis. The primary goal of pharmacological treatment is suppressing the underlying immune insults. Halting this attack gives the podocytes time to regenerate and restore the barrier. Standard high-dose oral prednisone therapy is the universal first line of defense. Clinicians monitor the urine daily, targeting a state of complete remission. This is defined as driving the urine protein to creatinine ratio down to 0.2 milligrams per milligram or less for 3 consecutive days. This diagram illustrates the critical 4-week diagnostic fork. The patient's response divides the protocol into 2 pathways, steroid-sensitive and steroid-resistant nephrotic syndrome. In the sensitive pathway, patients achieve remission, but many experience frequent relapses or become steroid-dependent when dosage is tapered. For these frequent relapsers, the clinical protocol requires escalation to steroid-sparing agents, such as cyclophosphamide or calcineurin inhibitors, to maintain remission safely. Conversely, patients in the steroid-resistant pathway fail to achieve remission within that 4-week window. This requires immediate escalation to first-line non-immunosuppressive treatments like ACE inhibitors, combined with alternative immunosuppressants such as cyclosporine. Long-term clinical management is dictated entirely by meticulously tracking these relapse patterns, allowing physicians to escalate treatment without destroying the patient's physiology in the process. That physiological destruction is a very real threat, as prolonged exposure to high-dose prednisone carries severe toxicity risks. Clinicians must guard against side effects like impaired statural growth, prominent Cushingoid features, and severe avascular necrosis. The physician is walking a clinical tightrope, applying just enough immunosuppressive force to arrest the podocyte injury while minimizing irreversible steroid damage to a growing child. Despite the severity of the systemic collapse and the toxicity of the required therapies, the long-term prognosis for properly managed pediatric patients is highly favorable. For the standard histological variants, the 5-year survival rate stands at greater than 85%. Pediatric nephrotic syndrome presents as a catastrophic multisystemic crisis. But underneath the severe edema and the clotting risks, it is a solvable structural problem, provided the clinician correctly maps the underlying cellular integrity to the patient's therapeutic response.